Good evening, everyone. Today we are discussing about secondary management of post-traumatic retinal detachments. In last class, we have discussed about open globe injuries, its primary management, and ocular trauma score, and how to calculate those scores. Uh, I am dividing my section in two parts. Later half will be some discussion of the cases, and initial part will be some theoretical part, how to calculate OTS and everything will be discussed. So as we all know, BETS classification, ocular eye injuries can be classified into two types. It can be closed or open globe injuries. Closed again classified as contusion and lamellar lacerations. Open globe again classified as laceration and rupture, and laceration again classified as penetrating, perforating at intraocular foreign bodies. So this is the classification of trauma. Open globe injuries and closed globe injury can be classified separately. There are four important points you have to keep in mind while classifying open or closed globe injuries. First will be the type of injury, then the grade of injury, then the pupillary reaction, and then the zone of injury. If you consider open globe injury, type will be rupture, penetrating, intraocular foreign body, perforating, and mixed. If you grading will be depend upon the visual acuity. Depending upon each step, we can grade. Grade 1, 2, 3, 4, and 5. Pupil will be positive or negative for RAPDs. And open globe injury zone will be, if it is isolated to cornea, it will be zone 1. If it is associated with corneoscleral limbus along with 5 mm posterior to the sclera, it will be zone 2, and zone 3 uh, away from 5 of the sclera. Then, in the same way, we can classify closed probe injury. Like type will be contusion, lamellar laceration, superficial foreign body, or it can be a mixed. Grade again in the same way, grade 1, grade 2, grade 3, depending upon the visual acuity of the patient. People in the same way, and zone will be different as compared to the open globe injury. It will be external, it can be anterior segment, and if there is involvement of posterior segment, it can be classified as zone 3. Then how actually we have to calculate for every trauma patient, we have to calculate ocular trauma scores, and how the main thing how it is calculated. So in the left side, you can see there are three steps. The first step, we are going to see the visual acuity. If patient is having no PL, we will take raw point and 60. Uh, uh, Hand movement, it will be 60, and accordingly we can just take the raw point in step 1. Step 2 will be, if it is a globe injury, we have to deduct 23, and end of 17, perforating injury 14. Accordingly, we will subtract these negative raw points from visual acuity points, and finally we get a raw score. If the raw score is falling in 0 to 41, ocular trauma score will be 1. The higher the OTS score, the more favorable the prognosis is. The OTS score is only done to get a prognosis after intervening, how much the patient can get vision. So on the basis of that, we can just calculate the ocular trauma score. Then blunt trauma manifestations are many. If it involves optic nerve, it can be a traumatic optic neuropathy, optic nerve avulsions, vitreous hemorrhage, opacity, detachment, or prolapse. Choroid, it can be a choroidal rupture, hemorrhage if it involves retina, commercial retini, tear detachments, macula, hole. It can be a pigmentary degeneration of macula. Uh, but today we are only discussing about the retinal detachment part. So these are the manifestations of penetrating or perforating injuries. They can present as retinal detachment, vitreous hemorrhage, intraocular foreign body, dislocated lens fragments, optic nerve avulsions. So why we are discussing traumatic as a separate entity? We should know the traumatic retinal detachment are slightly different from the non-traumatic retinal detachments because they are difficult to manage. But why is it so? It can be traumatic RDs are highly variable nature, often uncertain preoperative anatomy, increased risk of complications like intraoperative hemorrhage. It can be a PVR and postoperative IOP fluctuations. There is some research. There are some papers in which they have told okay, the incidence is quite high, incidence of PVR is quite higher as compared to non-traumatic retinal detachment. And there are some studies who also says if you inject 5-fluorouracil or low molecular heparin during the vitrectomy, the PVR changes cut to half. So these were the theoretical part. We will just start discussing case one by one. So this is a case one, 16-year-old male, history of cricket ball injuries 2 months back. He had some kind of redness for which he consulted a local doctor, and he was given some topical and some oral medication for that. After 2 to 3 weeks, he developed gradual diminution of vision and consulted us. Right eye had a vision of hand movement with the IOP of 3, and he had 360 degrees of angle recession. Other eye was absolutely normal. We dilated the patient, we seen the fundus. What we found that was a total retinal detachment along involving the macula. There is superior temporally and superior nasally vitreous base avulsion was noted, and two significant areas of retinal dialysis was also noted. Other eye fundus was normal. So you can see the optos image here. So you can see the avulsion part you can see in this particular picture. So this is the vitreous base avulsion area. Then for this, how the OTS can be calculated?
Hold on. Yeah. What type of injury?
Sir, closed globe injury,
Closed
sir.
globe injury. Okay.
Grade, sir.
Type closed globe. In that there are different types of closed globe, right?
Sir, posterior part is involved, so grade 3, sir. There is vitreous base avulsion.
Grade is based on the vision.
Sorry.
So you're telling the zone.
Type, sorry.
Type is
Type is closed globe injury with
closed globe injury. What are the types of closed globe injury?
it is contusion, lamellar laceration, and
Superficial foreign body.
superficial
and
foreign
mixed.
body. Yes.
Yeah. So of this, what is this?
This is contusion.
Contusion. Okay. Grade. The
Grades.
vision is hand movement.
Vision is hand movement, so grade 4, sir.
Grade 4. Okay. Pupil.
Pupil, sir.
There was no RAPD. you
No
told,
RAPD,
okay.
so
Zone 3 you told.
zone 3, sir.
So can you tell the ocular trauma score from the other details? You have to calculate. Okay.
You'll have to.
Okay, Abhishek, you can tell us about
Yeah.
calculation.
So it was a closed globe injury with contusion. Grade was 4 as per hand movement was concerned. There was no RAPD. Zone was 3 and OTS was 2 as raw point was 59. Like we have taken the hand movement like 70. We take the raw point as 70. Patient had retinal detachment. We have just subtracted 11 from that 70. So it came to 59. So 59 was the raw point and OTS will be 2 for this patient. So we took the patient for scleral buckle, and we just opened the 360-degree peritomy we have done with radial incisions. We have made the partial scleral thickness tunnels in 3 quadrants, like superior temporally, inferior temporally, and inferior nasally. So the main point while doing the scleral buckle is the indirect ophthalmoscopy. That is very important while doing the scleral buckle. You have to localize it and which type of band which type of scleral buckle we are going to use depending upon the location. That is quite important. So we have just measured the distance, and then accordingly we have put 277 scleral buckle, which is around 7 in length, and we took 1 sutures from the either side. So that will be 11 sutures we have taken. We have taken 3 anchoring sutures, which were between the superior nasal part. You can see here. These are the 2 anchoring sutures, and 1 anchoring suture we put here. And one is localization is important, and then the cryo is quite important to just seal all the break area or the dialysis area. Paracentesis is also important because to stabilize the IOP for the patient, and it was a non-drainage type of scleral buckling. We can drain also depending upon the situation of the RD. So this was the post of Optos image. We can see the scleral buckle can be beautifully seen here. It was a avulsion in this particular area. A small area of dialysis can also be seen in this particular area. Then what we have learned from this particular case.
Hold on. Next person. So can you tell me the 7 rings of trauma?
Yes. Iris sphincter tear.
Okay.
Then we have iridodialysis.
Okay.
Then cyclodialysis, trabecular meshwork injury. Then angle recession. Then zonular dialysis and retinal dialysis.
Very good. Okay.
So these are the 7 rings in trauma. So what we have learned in this particular case, basically in blunt trauma, we the typical breaks are retinal dialysis or mid-peripheral breaks. Traumatic retinal detachment usually slowly progressive because of the formed vitreous. Simple scleral buckle will suffice. You can just go for scleral buckling. As the patient has 360-degree angle recession also, so there are more chances of developing IOP fluctuations. So we have kept the patient on regular follow-up for glaucoma evaluations. So moving to next case, 23-year-old male patient with a history of trauma with stone 2 months back. And for that, he was managed conservatively elsewhere. Oral steroids and anti-glaucoma were started because the baseline IOP was 46 at that time. Right eye, he just visited us with the right eye vision of hand movement, intraocular pressure of 4, and anterior segment finding where there were some old scars. AC had some vitreous, traumatic subluxated cataractous lens was seen, and superiorly inferior area angle recession was present. Other eye was absolutely normal. So this was the anterior segment picture, though we can see some vitreous part and the rest of the things I have told. So after dilatation, we have just seen in this patient. You can see the macular hole in this particular area. Here, the macular hole can be seen with sub adjacent SRF is also present, and this is the retinal detachment which can be seen in the inferior part. But in this patient, we have suspected this. There is some kind of some foreign body we are suspecting in this particular area. For that, we have done ultrasound as well as CT scan. Uh, Again, we have to just classify the
One
OTS
minute.
score
Next
for this
person.
patient.
What is the type of injury?
So closed globe injury
Closed globe injury. Okay.
and vision.
Which
Grade
among the
4
types? Closed
vision
globe? Is it a
and
contusion, lamellar laceration?
contusion.
It is a contusion. Okay.
Hmm.
What is the grade?
The grade 4,
Grade 4. Okay.
then pupils, RAP.
He told there is an RAPD. Okay.
RAPD present.
Zone?
3. Zone 3
Zone 3. Why zone 3?
because posterior.
That is a retinal detachment. Okay. So there is an involvement behind the posterior capsule.
Ah.
Okay.
Yes, sir.
So it was a closed globe injury, contusion, hand movement. So we have given grade as 4, RAPD, zone 3. We have just calculated raw point as 49, and OTS was 2. According to this chart, this particular chart, you can use it to calculate the raw scores, raw points. Then, as I already told, USG and CT scan was done in this patient. So USG was suggestive of the subtotal RD in all the quadrant except the nasal part. And there was no IOFB noted in this particular patient. Axial length was slightly less as compared to the other eye. CT scan was also done in this patient, which was absolutely normal. There was no evidence of any foreign body. Then, as the patient had full thickness macular hole along with chronic RD with a history of 2 to 3 weeks with subluxated lens, so we posted this patient for lens vitrectomy, ILM peeling, belt buckle, and silicone oil insertion under GA. Yeah. So, intraoperatively, what we have done in this condition to pass the belt buckle, we have already we have done the peritomy 360-degree with the 3 and 9 relay incision, open the sclera, but just check the sclera whether there is no thinning or not. And we have just make the partial thickness uh, scleral tunnels, and we pass the buckle in this. When we went inside, we have seen these two areas which are suspected of dialysis in this particular area, and patient also had the macular hole. For that, we have just put billion blue dye, and we just remove the ilum. We have done the ilum peeling in this particular patient. Along with that, we have done the cryo and the laser marks over this particular area. The main key points here, already we have planned for lensectomy, but we just tried to save the lens because the visibility was fine and there were not so much subluxations so that the lens can be removed. So we just avoided lensectomy. And one thing what we have done in this particular case, we have drained SRF from the macular hole only. There are two concepts for the drainage of SRF from the as far as macular hole RD is concerned. We can make the best is to make a retinotomy and to drain the SRF from the if the patient is having macular hole RD. But in this patient, we have just drained the SRF from this particular macular hole only, and it was very passively. It's a very slow process, so that we should not injure the RP which is behind the macular hole, and we should not increase the size of the macular hole also. So that was a very slow process, but better to go for a retinotomy for draining these types of macular arteries. So, according to vitrectomy with subretinal fluid drainage through other side than macular hole may avoid possible damage to macula, as I already told you. And the conventional procedure of drainage through macular hole, both in anatomical and functions, gives slightly less comparable result as far as retinotomy is concerned in these type of macular hole with RD patients. So, what we have learned from this particular case, vitrectomy planned in view of presence of RD with macular hole, SRF drained from macular hole itself. No need for any retinotomy in this particular patients, but always option is always there for retinotomy, so that we do not enlarge the macular hole. ILM peel was done to for the better closure of macular hole. Bell buckle was planned, but if we have done extensive RR, then the option of removal of the bell buckle can also be done. USG and CT scan was done to rule out the foreign body because the history was totally unreliable, and initially we are suspecting of a foreign body. So this case is open for discussion.
This was a blunt trauma, right? And CT scan was done to rule out IOFB. So what makes somebody to do a CT scan if you are very sure if it's a blunt trauma? Or is there any reason for you to go ahead with CT scan?
Sir, blunt trauma cases, we need to rule out orbital wall fractures also.
But
So-
it was done here to rule out intraocular foreign body.
Right eye cornea had some scar, is what he had mentioned.
Okay,
So-
so
If there was possible entry of a foreign body or
okay. So if you have a little doubt about the penetrating injury versus clear-cut blunt trauma, then you are justified in doing CT scan. Okay.
Also, sir, there can be a risk of occult tear because of the impact. Occult tear site can be other than the site of impact. So it might be the entry site for foreign body.
True, but a little more speculating, like rather than you really come across. If there is a slit break or something, you have the same thing, the entry into the iris, entry into the lens, everything. You should get one more clue for you to
Yes.
anticipate that the foreign body has entered the eye inside.
Yes.
Correct.
If there's a posterior rupture or something, so do you think CT will be good in picking it up?
No, sir.
Which investigation would you want to do?
So USG can indicate.
Ultrasound
occult
would
tear.
be better,
Yes,
right?
sir. Yes, sir.
Yeah.
Better.
MRI can also pick up, but an ultrasound, a carefully done ultrasound would be much
Will
better,
be better. Yes, sir.
in picking up posterior lobe vessels.
Moving to third case, he was a 50-year-old male who has a alleged history of RTA 2 weeks back. Left eye developed sudden diminution of vision with periorbital edema, for which he has visited local doctor and started with some oral medications. Right eye had a vision of 612. Left eye had no PL, IOP of 7. RAPD was present. Lens was clear, but there was no angle recession seen in this particular patient. So that we have directed the patient. We have seen the right eye was absolutely normal. The fundus was quite normal. Left eye, he had a dense vitreous hemorrhage. Again, we have checked for PL. PL was totally negative in this patient. We have checked in a dark room with the help of IDO. And later on, we have done the USG also for the who showed that USG showed heme with retinal detachment. Now, before going to actual USG, we will just classify the OTS score.
Is there any way to know how he got injured in the eye? Abhishek ji?
Yes, sir.
Yeah. Is there any way, no, you just said RTA. Is there any way that we can know exactly the mechanism of injury to the left eye?
So
Was there an associated orbital fracture? Was there any associated injury to the
so there was some.
adnexa?
We can just check for.
No.
Yeah.
History. I'm asking, was there history, any additional history?
Uh,
How he got injured in the eye?
No, sir, he didn't give it. Actually, he just told he had got. I mean, while driving bike, he got he got struck with
Did he
some.
lose consciousness at the time of injury?
No, sir, nothing like
So
that.
he was aware of the injury.
He
to
was
the
aware
eye.
of the injury.
So he would have known exactly how the eye got hit.
Yes, sir, but he was not able to.
There were no adnexal injuries at all.
So there were some abrasions were present around the eyelids.
No ecchymosis.
Ecchymosis was there at that time, sir.
No, he has come to us immediately after injury or much later.
No, sir, after 2 weeks around.
After 2 weeks.
Yeah, 2 weeks around. sir.
So who's telling the score? Yeah, Saurav.
So
So forget about all the grading. It is of no use now because there's no injury at all. It's a contusion injury. Leave it.
contusion
You
type,
tell me what are the causes for vitreous hemorrhage? There's a vitreous hemorrhage. Grade 1, chalo, let's.
grading, sir.
Yeah, okay, tell the grading, no problem.
Type is contusion.
Okay.
Grade 5.
Hmm.
As the region is no PL, RAPD,
Hmm.
zone 3.
Zone 3.
Posterior segment.
It's called zone 3. Yeah?
Any damage posterior to the posterior capsule and a closed globe injury is zone 3.
Okay. So what is the OTS score? 100, no? 100, huh?
No, 1 or 2 something. Sir.
Is NPL, no?
But that has got a minus thing actually. I think start 60, right?
Yeah. So basically, this chart gives us the
From 60, you have to
raw
subtract
points.
what?
So we have to subtract in this patient has RAPD. We have to subtract 10, RD for 11. So we have added 11 and 10. That will be 21, and that will be subtracted from 60. So it will come 39, and we have to see this raw score here, and accordingly we can just classify as. So the score is 39. So it is coming within 45. So that OTS score will be 3 in this patient.
3, 1. 1, no?
Sorry, yeah, it's 1.
1. You can read your chart also. It's there. It's written down there.
Yeah, yeah.
It's 1. So yeah, you tell me what is this vitreous hemorrhage due to? Causes of vitreous hemorrhage. Where everything is normal anteriorly.
So
And then there is NPL. The
There
causes of vitreous hemorrhage in a blunt trauma with clear anterior segment with no injury to the anterior segment.
There can be some large break causing vitreous hemorrhage post-burn trauma.
Okay.
There can be damage to the angle structures. Now the anterior segment is normal, you see.
Mm.
There can be a dialysis,
Dialysis causing hemorrhage. What dialysis cause hemorrhage?
traumatic suprachoroidal detachments with vitreous hemorrhage, optic nerve avulsion, or sometimes there can be RT related, the Terson kind of, if anything related to that. So that history of unconsciousness and all has to be elicited.
Correct.
Occult globe rupture, sir.
Occult globe.
The ultrasound is showing no such problems here.
PVD induced
And occult means really be occult. It will be really behind the muscle origins also.
posterior.
Much posteriorly. And if there is a
Acute PVD
rupture
induced
posteriorly,
CVD.
most likely, if there is vitreous hemorrhage, most likely there will be incarceration. And RD will not be this. I don't know. You'll show the ultrasound, correct?
Yes.
Then you'll know from the RD, from the way the retinal detachment is there, whether there has been an occult globe rupture. It's come after 2 weeks. You probably not see anything anteriorly. So occult, if it is occult, it's really behind the muscle ring, where you can't see clinically pigments and all that stuff. Fine. You're showing the ultrasound?
Yes.
Yeah, sure.
Yeah. So this was the ultrasound which was suggestive of vitreous hemorrhage with suspected retinal detachment, and there was no definite sign of posterior globe dehiscence. Axial length were comparable in this patient.
Just keep that ultrasound. Aditi, yeah, if you go back retrospective from the surgical, what you saw and the ultrasound, you want to defer the findings now? You had assisted the case,
Yes.
and you know a little more about this case now. So there was some changes noted intraoperatively, and which differs from what the ultrasound is showing. What is that? So that default sentence, right? No definitive sign of posterior globe dehiscence. So it need not be posterior globe. Anywhere the dehiscence, So it's if it's done very meticulously, you will be still able to pick it up. Okay.
Incarceration superiorly of the
Okay.
vitreous.
Where?
Superotemporally, sir. On table, that was
No,
noted.
where is it? Behind the muscle ring? Because it's obviously missed clinically, anteriorly. There's no pigment, there's no scarring of conjunctiva, tenons, nothing. So it
Behind,
was-
sir. Behind only. Behind the muscles insertion.
It was behind the muscle insertion only, sir.
Has to be no, because you're talking. you,
I just
you have an incarceration, retinal detachment. Was the retina also incarcerated in that?
During the first case, I wasn't there. I was there when he had a recurrence. So that time, I don't know what has happened in the first case. When the patient was first taken up, I was not there.
So any clue is there in the ultrasound which tells that there could have been an incarceration or there is a discontinuity of the globe or there is something which is not normal?
That is the what I wanted to ask you. So if the ultrasound can be done little more time taking to pick up these little rare things, because if there is no classical history of any injury to the eye and you don't see any injury externally, so ultrasound should be done little more extra effort to look for these things which can be correlated clinically during the surgery.
See, so surgery, they have diagnosed it as a TRON, that is traumatic optic neuropathy. So do you think that is the actual diagnosis, is NPL?
so the patient had the vitreous heme along with suspected RD. So we just and the patient had no PL also. So what we have suspected key retinal detachment will not cause no PL to the patient. There is some optic nerve pathology is going on with the patient. So we just suspected of traumatic optic neuropathy in this patient. And CT scan was also done for this patient to check whether the optic canal fracture is there or not. Sometimes, if the patient is having optic canal fracture, there will be impingement of the nerve, and that can lead to no peel also. There was no intraocular foreign body. Then for that, we have done the VEP. VEP was not recordable. You can see, and this left eye is not recordable. Then we have started with steroids with 70 milligram, with 1 week tapering, and we called the patient after 5 days. When patient came after 5 days, the situation was slightly better. The patient who had no PL at that time uh, s- has developed nasal PL in this particular after 5 days of starting steroids. And again, we have repeated the
There's
VEP.
nothing called nasal PL, man. You have to tell.
PR, sorry.
Projection of ray.
Yeah, PR, nasal PR was present in this after 5 days of follow up. Then again, we have just repeated VEP. VEP was still there was no response in VEP, and now the question arises whether a patient having no PL should be operated or should be intervened or not. The answer is yes. Can be a trial should be given in this type of patient, as the patient was middle-aged man, recent history of trauma. So we just consider a trial of vitrectomy, endolaser, SOI with additional procedures. So we have also repeated USG. Now we have in this USG we just picked up the incarceration of retina at in SNQ quadrant along with the subretinal heme. So patient got operated after 3.5 weeks of trauma. Uh, we have kept our option open for belt buckle also in this particular patient. We have just done the peritomy 360-degree with real incision at 3 and 9. While doing the peritomy, we just observe an occult type of trauma, occult rupture. We have seen there was incarceration of the tenons in the sclera while dissecting the tenons just posterior to the muscle ring. And we have just started with vitrectomy layer by layer. We just dissected everything. Slowly, we have just dissected the vitreous and the vitreous hemorrhage part. In this particular area, we have seen the subretinal heme with bullous retinal detachment, and this particular area of this area had incarceration of the retina with the bare choroid. So what we have done in this particular case, though it was a blunt injury, after that also we got a occult rupture, which was which were only present, which were only seen after we have done the peritomy in this particular patient. Lensectomy was done in this patient to get a better view, As this area was incarcerated, so what we have done, we have just done the 360-degree. RR was done, and we just the retina settled back, and we just done the endo laser in this particular patient with silicone oil insertion. And post-operative day one, the patient was doing well with the IOP of 14 mmHg.
Hold on. What other options can be done instead of? Do we need to do a 360 RR?
Sir, as the patient has incarceration over here, if we didn't done the RR, the retina would not have been settled.
No, he's asking 360.
We could have done only a localized RR, right? Only near the site of the retinal incarceration. Cut it off from the rest of the retina.
Yes, sir.
Keep the rest of the retina there. Yeah. In this case, it was not attaching. Even after putting LPFC, there were fixed folds inferiorly already forming.
Yes.
So that's why we had to do a 360 RR. Any other thing which has been described for such posterior vitreoretinal incarceration? Anybody?
Chorioretinectomy, you can just go
What
for
is
that.
chorioretinectomy? How do you do chorioretinectomy? Anybody else?
Sir, 100% diathermy is applied to the
Okay.
areas, the area of interest for doing the chorioretinectomy.
So basically, you remove the retina and the choroid from that side so that you reduce the chances of post-operative PVR. Okay. So here we could get away with only a relaxing retinectomy. We did have PVR post-operatively, but yes, if you had done a chorioretinectomy, that means cutting off the choroid and the retina, everything together. You have the bar sclera there. They tell that the chances of PVR are less. Okay.
So the most important point is don't do it. Don't do it. It is a radical surgery. Why do you want to do a radical surgery when there is not at all, there's no 100% guarantee that PVR will not develop? You think PVR is something which is there only if you see it? There are cells moving around everywhere. They will eventually develop this thing. Trauma is such a case where PVR can develop many, many years later also. So there's no point trying to remove what is already there in the eye. Don't take additional tissue from anything forever. What is there, preserve it. What is not required, you cut it off. In this case, I would like to ask, were you able to induce a PVD?
Yes, sir. PVD was induced up to this thing, like the incarceration. There I had to cut off the vitreoretinal tissue there. One more risk.
Why did you put a belt buckle?
I had initially planned. I had not was not expecting this kind of detachment inside.
No, but did you open the conjunctiva?
I opened the conjunctiva and yes,
made all the
made the tunnels and kept it for this case. One other thing why I did not do a chorioretinectomy here was because there is a risk of opening up the posterior scleral wound. So because the vitreoretinal tissue and the actually the tenones, everything is actually forming a scar there. So this is again 3.5 weeks post trauma. But if you are operating like within 2 weeks or something, that healing would not have happened that well. So when you are trying to cut off tissue there, you might actually open up the posterior wound. Then it becomes very difficult because you can't suture from behind. So it is very difficult situation there.
So we call this patient at the GA appointment at 6 weeks. Vision improved to 612 with near vision of N18 with IOP of 14 in this patient. This was the post-operative optos. In this, you can see the area. This is the incarcerated area which can be seen superiorly, and these are the retinectomy areas can be seen along with the laser marks. There's some amount of fluid can also be seen in this picture. There's some amount of SRF was also there. So we have done the OCT also. So the foveal part was totally attached, but here the SRF was present.
So why do you think he had NPL? This doesn't look good at all. But why do you think he had NPL? It's a dramatic increase from whatever you have shown before to now.
Still, we are figuring
and then
out.
VEP was negative.
Yeah.
There were no, and now suddenly it's 612.
So in the later half also the VEP is negative, but still the patient is. But still
Now
we
did
are
you
not.
do the VEP? Should have done the VEP now and seen.
That is what.
Huh? Next visit done. Is it okay? No? There's no.
Still no response was there in the
No response.
Yes.
So again, I'm wondering 612 is correct?
Yes, correct. it improved more in the further course of
Something
time.
doesn't add up. VP is gone. NPLI becomes 612.
Yes, sir.
So where is the connect here? I can't understand the
Yeah.
connect there. So
So
again, I told you, the VP is of no use to us. What you see PL becoming 612 is totally useless investigation. Again, it didn't help you at all in making
Yes.
decision. You took a decision based on his age
Yes, sir.
and the pathology. You
And
never took a decision based on VP.
No, sir.
You did VP, okay, that's
Yeah.
done just for
The
medical legal
supplementary
purpose.
we have done the VP.
Yeah, but you
as-
see, you took your decision completely clinically.
exactly.
But your diagnosis of Tron was probably plus minus.
Hmm. Initially, we thought of blunt trauma, but when we opened the peritomy, we got to know a patient is having rupture also.
So again, I'm insisting you don't depend on VPs. Tomorrow you go and practice and you think, "Oh, without VP, how will I practice?" That's not the right to do. They took a chance on that guy's age, clinical condition, and did a surgery. And if seemingly got a good result. So don't believe that if I don't VP, if you are ERG, I can do surgery. It's not the case at all. Clearly, you have to believe what you're seeing. In TRN, he is saying, TRN is really, with a multiple pathology drawn to put a diagnosis of traumatic optic neuropathy is a little question mark. There are multiple pathologies here. The media is absolutely clear. Then he had NPL, and then you said he could have said that yes, there's nothing else except for the optic nerve which can get involved. So the diagnosis is because of subretinal hemorrhage. It is subretinal hemorrhage. Subretinal hemorrhage, you also know. What is a time limit where you allow the subretinal hemorrhage to be before you take a decision of not doing anything? What's a timeline? Say somebody has come with a massive PCV-related bleed. The PCV is, the polyp is somewhere outside the macula, but the hemorrhage is at the macula. What's a timeline you will think of doing pneumatic displacement, say? This is a simple things you should tell. No, tell the Mike. What does the literature say?
2 weeks.
Yeah, roughly 2 weeks, that's it. You don't go beyond that. And then you don't have any visual potential because the photoreceptors are completely disorganized by that time because of the blood there. Right? So in this case, there could be a possibility that it could have been, there's a lot of blood inside the eye, incarceration. So it's quite possible that his NPL could be because of that. When blood is there, it can give you all kinds of poor vision. The blood, that subretinal hemorrhage is very good diagnosis there. So incarceration with blood subretinal hemorrhage, yes, patient can have NPL. Maybe there are just a few, what do you call, surviving photoreceptors, so he's seeing 612. Maybe that is the case. The nerve is not so bad if you look at it. Not nil VP kind of thing. Nerve pretty looks okay. It's not atrophic at all. So his 612 can be expected in this case. There's nothing wrong in that. VP doesn't go with this. That's all I'm trying to say. So please don't look at VP for diagnosis. What you did was absolutely fine. You got a good result. And that's great.
Oh, so like there are, like when I saw this patient, there were like a few papers on this thing also that VP may not be the right way to go in cases of vitreous hemorrhage. It may be falsely negative. They have noted a few papers. Like
Yeah, when you have an 8-ball hemorrhage, say
Yeah.
for example, full chamber ifema, you do a VP, you might get negative also. It's a flash response. It's a totally flash response. It's really high flash stimulus. It may not reach enough to get a record on this. So it may not be always, the nerve is, it has to get stimulated, right? Something has to stimulate the nerve. So because of the blood, there may be a lot of pathology there. It's after all phototransduction happening and then a neural response to it. Maybe not, it's not possible probably when there's blood, everything. Probably maybe not really truly useful to you. I feel that VEP should be done when you see clear media and the optic and you cannot explain the vision. That helps you in some way. Maybe even RAPT is not classical in that case. Then it helps.
Then they will PVR membranes were present. For that, we have just waited for at least 1.5 to 2 months so that they get matured and so that we can plan another intervention for this particular patient. At that, after 2 months when he came, the vision was 6.9, IP was 14 in this patient. Though the SRF was increased, initially it was slightly here, but slightly it has been increased, but it's not involving the fovea part. So persistent SRF was there in this particular picture, and here's the OCT of it. You can see the fovea part is still attached, and there is presence of SRF. Then we had just posted the patient for RR, limited RR, endolaser, and re-SOI. So actually, oil field globe have two options. Either we can go for the SOR, then we can do the surgery, or with the silicon oil in situ also we can do the surgery. So this surgery we have done with the presence of silicon oil inside. We just located a ITQ break, and limited RR was done in this patient, and the laser is done in this particular area. So we have just sealed the break and just we followed the patient next. So this is the post-op picture. The SRF was gone in this, and this was the limited RR and laser marks after that. So when we done the OCT was totally this was fine. The fovea was well attached, and the rest of the retina was also looks attached. And patient came at GA with a BCVA of 6.9 with a near vision of N6, and the IOP was also normal with a 16 mm of HA. Yeah, this is the after second surgery, GA was called. This is the optos image. This is the OCT, which is showing the flat retina. We have also done ARG in this patient, as we have done the extensive RR. The ARG was totally flat in left eye. We also offered for multifocal ARG, so we can just see some small peaks can be seen from the central part, which is still active in the part of the fovea. We have done the HVF also. 30-2 was showing total depression of the fields over here, and then we also planned for 10-0 HVF, which shows some area still working in the area of macula. So what we have learned in this particular case, posterior globe rupture can be present in blunt trauma, suspect in soft eyes. Here, occult open globe injury was initially misdiagnosed as closed globe injury. Again, then we have just changed our diagnosis. It was an open globe injury, and it was not a contusion, it was a rupture. Careful USG can pick posterior globe rupture, which was primarily missed in the initial scans. Surgical attempt should be done if the patient is having no PL. Rarely we can get some good results, as in this case. Extensive RR does not always mean a low IOP or poor vision.
So his 6.9 was because of the central photoreceptor, which is
Yes.
still there.
Yeah.
You could see it from the first two cases, there were no ellipsoid zones seen in the OCT, but in the last, you've seen some foveal ellipsoid zone is seen. So that means photoreceptors can recover. That can explain the 6.9 vision and only that small hill of vision at the MFERG.
Yes. So
we must congratulate Jaya Prakash for doing this, right? Yeah, and extensively he was inquisitive enough to find out why this man has got 6.9 vision. So he found out that the MFERG is still working. Still working.
Yeah. So moving to
but his visual field is 0.
Yeah, but only 10-2 had some areas working, but 30-2 was not totally depression. Moving to case number 4, 23-year-old male patient who had a alleged history of fall from the bike, and after that he developed sudden diminution of vision in right eye. Elsewhere, he underwent limbar tear repair and started topical and oral steroids. So he has a history of SFL also in 2015. He came to us with a vision of PL/PR inaccurate with the IOP of 7 with limbal sutures intact with hyphema and aphakia in this patient. This was the slit lamp examination findings. It can be seen. It is the slit lamp image, which can be seen by some sutures over the limbal area. And just we seen the fundus, so right eye fundus was not seen, the PL was present. Other eye had SFIL, but still the dislocated lens was also there, which was there in the vitreous cavity. So finally, we just calculated our OTS score, USG, which was suggestive of vitreous heme, and shallow RD and shallow CD was present in this patient. Then we had just calculated our...
next person. Zubin, yeah. What is the type of injury? Open globe, closed globe, open globe, What type?
Open globe rupture.
Rupture, okay.
Vision is
Grade,
PL.
okay. Vision, what is the vision? PL plus, okay.
Yeah, PL plus.
Okay. PL plus would be grade?
Grade 4.
Grade 4, okay.
Uh,
RAPD,
RAPD won't be able to
okay.
tell
Zone,
in this.
what is the zone?
1.
Zone 1?
Zone
Limbus is involved.
Limbus, yeah, 2.
Zone?
2.
2, okay.
So these are the raw points. Raw point was 26. Zone 2, inverse RAPD was present. PL and rupture. The OTS scored 1 with raw point of 26. So from this chart, we have just calculated the OTS. USG was done, which was suggestive of vitreous heme along with shallow RD and CD. We have just increased the dose of oral steroids and just posted for VR intervention as vitrectomy, belt buckle, EL, and SOI with additional procedures. As soon as the cornea, because the cornea was quite hazy, so we just restricted ourselves to immediately when didn't intervene in this patient, we just increased the dose of steroids and we just followed the patient. And also the RD was not we are not very sure about the RD also. So we waited for a time. We have increased the steroids. So this is the next follow we have done. Repeat scan was done. Shallow RD was present in ITQ area with serous CDs in ITQ. Patient was symptomatically better.
Can you point out which is the RD, which is a CD with your pointer?
So this is the two layers we can see. This the front layer is the RD part, and this is the CD part. There are two hyperreflective membrane can be seen here.
So RDs are the slope of the choroidal detachment.
Yeah.
So it is a serous choroidal
type
detachment,
of
not
choroidal.
hemorrhagic.
Yes,
Okay.
sir. Along with some viticos can be seen, doticos in the vitreous cavity. So vision improved to hand movement close to face. We thought of waiting for 1 more week. And again, we have when patient came after 1 week, again we have just repeated our scans. So CD were reduced, RD was more obvious, cornea was clear. So we decided to go for the VR intervention as planned before. This was the present picture. The cornea was cleared much. Posted for the patient for with BBEL SOI and the GA. So we have done the surgery in this patient. The dialysis was there in superior temporal area. We have just cryoed this particular area.
That photograph was post-op photograph. There's a PI already there.
Which
the antecedent photograph is post-op photograph. It cannot be a pre-op photograph. Conjunctival switches are there. PI is there. Con is absolutely clear.
But that was yeah. After suturing.
After the belt bucklement.
No, sir. These sutures are.
No, what are the two sutures that side? Yeah, that side.
That is got repaired before for the corneal tear.
Then why is the PI there? Was an arteries there?
Dialysis was not there, but I think the initial surgery they have.
Suddenly the conjunctiva looks very suffused and thick.
No, Abhishek, this is a post-operative photo.
Yeah, that I'm telling you.
This is a post-op day one photograph.
Day one photograph.
Sorry for the picture, sir. So this is the area of dialysis where we have done the cryo. We have just found a small break near the aura superiorly. We have done the cryo to this particular area. We have passed the belt buckle in this particular patient. And the drainage retinotomy was done in this area so that the submacular subretinal bleed which was there, which can be drained from this drainage retinotomy. So submacular heme was drained from this retinotomy, but still the small film of hemorrhage was still present. So we just thought of leaving it so that once we give the prone position, it can disperse. Very thin submacular bleed was still.
Abhishek, if I may interrupt, that superior break was an iatrogenic break during the base shaving. Okay. Supratemporal dialysis was there, and there was shallow retinal detachment with extensive subretinal hemorrhage. Yes. So we tried to drain the subretinal heme through a drainage retinotomy. Again, this is a debatable thing because you can leave the subretinal hemorrhage and with putting a tamponade that can get displaced also. So that was an option, but here I thought the blood was liquefied and I thought I could drain it. So that's why I made a drainage retinotomy. I could drain some of the subretinal heme, but some of it was still left at the macular area. I had to put a tamponade definitely because there was a dialysis in the subretinal area.
Yes. So this is a post-op day 5. IOP was 4 in this patient. Patient had uh, some hazy media was there, but still the retina was attached after day 5. This was the optos image. We can see the drainage retinotomy over here along with the laser marks, and retina looks attached in this particular patient.
You can see the subretinal heme displaced.
Yeah, this is the
inferiorly.
subretinal heme which was displaced after giving prone position to the patient after putting the silicone oil. And after 6 weeks, BCVA from hand movement improved to 636, and this was the 6 weeks post surgery picture with the belt buckle silicone oil. There were few SRG bands was there, and there was most of the subretinal heme was resolved. A very small flex of heme was only present in this patient. This is the optos image. You can see the drainage anatomy. So what we learned from this particular case, oral steroids play a very vital role in a reduction of inflammation and CD post-trauma. USG was crucial in evaluating the presence of RD and choroidal detachments. Surgery delayed as not sure of presence of RD and corneal haze. Need to follow up closely with serial USGs. Though we have delayed our surgery, but still we have regularly followed the patient for the progression or regression of CD. Poor visual outcome probably due to prolonged presence of subretinal heme, and open globe injuries can have breaks typically seen in blunt trauma, right? Retinal dialysis. So now the question arises when to manage these type of patients. So there are two school of thoughts. One early school says that we have to operate within 3 days, which reduces the opportunity of inflammation, and the other late school recommends we should intervene by 10 day, which makes vitrectomy easy and a safer option. But most of the surgeons agree that vitrectomy should be undertaken before 14 days in animal studies. So moving to case number 5, 32-year male patient came to emergency department with a history of dog bite. He was pet dog to left side of the face 8 days back. Consulted locally, it was diagnosed as zone 2 open globe injury and advised for wound exploration and scleral tear repair. Already he took ARB treatment elsewhere. He came to us with vision of PL inconsistent with the IOP soft with hyphema lil laceration involving canaliculus. This was the slit lamp picture of the patient, and he had some DM4, severe chemosis was there. FT cannot be assessed because of the severe lid edema. Uh, we have seen the fundus because of the hyphema. We couldn't evaluate the posterior segment in left eye, but the right eye was absolutely normal. USG we have done, which was suspected of retinal detachment. Then again, we have done the OTS scoring in this patient.
Ashul?
Hello. Sir, open globe injury.
Okay.
Sir, type is penetrating.
Okay.
Sir, grade 4. Vision
Okay.
is PL. So zone it was mentioned that zone 2 outside diagnosed as zone
Okay.
2.
So we are not sure here because we couldn't examine the posterior extent of the wound. Okay. So it may be zone 2. Okay. Sure.
Then the injury was open globe penetrating, grade was 4, reverse RPD was present, zone 3, and OTS score was 3, raw points were 39 according to this particular chart. Then we done the ultrasound. Ultrasound was suggestive of hemorrhagic choroidals with suspected RD, and suspected posterior globe dehiscence can also be seen. This is the area of dehiscence which can be seen in ultrasound, and these are some hemorrhagic choroidals can also be seen here with a maximum height of 8.16 mm. Patient posted for primary repair on the same day and underwent lid tear repair plus clavicular tear repair with mini Minoka stent, and scleral tear was also done in this patient. The scleral wound was 7 to 8 mm from the limbus posteriorly in the superior part of the sclera. And after 2 days of primary repair, USG was again repeated. Again, the USG was suggestive of hemorrhagic CD with suspected retinal detachment, and PL was questionable at this time. We have taken the physician fitness for oral steroid to start the steroids in this patient. So this is the anterior segment picture of the patient. The cornea is quite hazy because of hyphema, because the staining of the corneal epithelium was also there, and the view was very hazy. Then again, USG we have repeated after 5 days, which was a study of hemorrhagic CD with total RD, with evidence of some clot lysis was also seen. The patient was on steroids at this time and period was inconsistent. Again, we have done a VEP in this patient, and there was no recordable waveforms can be seen in VEP. The patient was planned for vitreoretinal surgery under corneal backup because the cornea was quite hazy. So we just anticipated whether we can do it without or with cornea backup. So we have posted the patient after 20 days after primary repair. So we in this patient as the PK was anticipated, we just put the Flerenga ring before going in this patient. So we just started with high-risk eye hooks so that the additional visualization can be done. We have done the lensectomy in this patient so that the visualization can be more clear. What we have visualized, this is the small area where the ciliary body detachment was seen in this patient. And after lensectomy, patient had the total close funnel type of RD, which was touching the posterior capsule, which is coming anteriorly. So already we have planned lens with EL, RR, LPFC, SOI and the GA in this patient. After the operation, as I already mentioned about the flare ring, why we put the flare ring, lensectomy already told about. Uh, because as this port is inferotemporally, because of which there was some extension of ciliary body detachment was going on. So we just removed the infusion from this particular area. We just make a side port over here, and we just put that cannula only. We just put as a AC maintainer in this patient. So we just yeah. After doing this, gradually we have dissected the vitreous part, and we have put the LPFC after doing the RR, and the retina settled well in this patient along with the endolaser at the margin of the RR. And we have at the end of the operation, we have also injected posterior subtenon steroid injection was also given in this patient. So this is the post-op picture we can see with the RR margins along with the laser marks. So we just called the patient after 6 weeks at GA. The pressures were 12 normal, and the vision was 6 improved to 612. So this was the fundus picture of the patient. The retina was well attached. Old marks can be seen. Periphery, we have he had a lot of membranes, which can be seen here. This is the optos image. We can see the retina is well attached, and the laser marks they are like old marks. So what we learned from this particular case, meticulous management of hemorrhagic choroidal detachment, iris hooks we have used, which have given the extra edge for additional visualization. As the cornea was hazy, VR intervention was done with PK backup, but still we didn't transplant, we didn't went for PK. And we have preferred 5000 CST in this patient because we are anticipating that as the ciliary body detachment is there and post-op hypertony may occur. So we have just preferred 5000 CST oil in this patient. So there is some literature which is telling how to deal with hemorrhagic choroidals, when to deal with. The classic recommendation to deal with the hemorrhagic choroidals in the wait time of 10 to 14 days. Just wait for the liquefaction of the hemorrhage so that it can be drained well. Serial USG should be taken so that the clot lysis can be recognized early and so that we can intervene accordingly. According to American Society of Retina Specialists, there is a stepwise approach is also published in the Journal of Vitreoretinal Diseases, which gives the stepwise approach of surgical management. Like if required, sometime injection of tissue plasminogen activated can also be done around to 12.5 to 50 micrograms during the time of vitrectomy, just before 15 minutes, so that the hemorrhage can be dissolved, liquefied. Anterior chamber maintainer, if you're not able to see the cannula, so we can go for anterior chamber maintainers. Trocar cannula insertion is quite important. We can use 23 to 25 gauge trocars, and it can be put 6 to 8 mm from the limbus with the angle of 20, or it can be parallel to the limbus. Either way will suffice. We can increase the infusion pressure and application of external pressure so that the the fluid which is present in the supracarotid space can be drained out. And then next step, if this is not subsiding your CDs, go for connection to active aspirations. We can also opt for second trocar cannula insertion, or we can extend the sclerotomy in the last step. Moving to next case, case number 6. So, a 26-year-old male patient who has alleged history of trauma to left eye while working on hydraulic pressure machine developed visual loss with diminution, sudden visual loss with the history of bleeding from left eye. Left eye had a vision of PLPR inaccurate in 3 quadrant. It was soft with corneoscleral tear. So this was the situation of the patient. The tear which was extending from 3 to 7 o'clock, involving the sclera part, and along with the full chamber hyphema. The fundus was not seen. Other eye fundus was normal. USG suggestive of total retinal detachment. Again, we have done the scoring in this patient. It was an open globe injury, penetrating wound with a grade of 4, and OTS was 2 with a raw point of 45. So he underwent primary tear repair, wound exploration plus tear repair on under GA on 11th of March, after a few days after injury. This was the post-op anterior segment picture. It is well sutured, and there was full chamber hyphema along with some corneal edema can be seen, and you can see some sutures over in the sclera part. IOP was soft. Again, patient came to us after the primary repair. We have done the ultrasound. Total retinal detachment, his degree was there with the hemorrhagic CDs with vitreous hemorrhage. OU axial length was comparable, and presently in the PL was present and PR was inaccurate. Started with oral steroids. Again, after a few days, we have just repeated our scans. Again, the situation was uh, same. It was like slightly deteriorating because the axial end showed a difference of 3 mm in this patient. IP was still soft. Again, we have repeated the patient, but we are just repeating repeating the scan so that the hemorrhagic CD can be analyzed for a lysis part. So this is the scan suggestive of hemorrhagic CD, but still the evidence of clot lysis can be seen in this particular image. You can see there is some clear area can be seen in this particular. So this was the evidence of clot lysis, and the axial is still reduced to 14 mm. Patient had the IOP of 4 with the PRPR inaccurate. So at this time, we have just planned for VR intervention under PK backup. So VR intervention was done after 14 days after primary repair. So this was the intraoperative picture of the patient. There was 360-degree choroidals were seen. Total RD was present with some subretinal hair in this particular area. This was hyperemic, and there were membranes over the retinal folds, which can be seen here. We have done initially. We have just done the choroidal drainage with the help of the cannula from the SNQ quadrant. We have drained the choroidals by starting the infusion and just using the cotton tube applicator, and with just a roll-on mechanism, the fluid came out from the SNQ cannula. And then we have just done as it was not settling down, so we have just done the RR. After that, LPFC was put to settle the retina, and the retina was settled well along with some retinal hemorrhages which can be seen on the edges of the RR. As in this patient, break could not be localized, so we have done the RR for this patient. This is the picture of 1 month after. Here in this picture, you can see there are more OCT picture. Here in this picture, you can see some LPFC bubble which are subretinally, along with some membranes can be seen in this area. So these are the LPFC bubbles which are just went under the retina. Waited for PR membranes to mature. At this condition, this is the area where which was lifted. Here the silicon oil was there under the retina. These are some LPFC bubble which can be seen here. So this was the picture. So this here you can see some LPFC bubble. This was the area where the silicon oil was there. So membrane were matured, IOP was low, formation of new break. We just thought of resurgery in this patient. So this is the comparative scan. You can see the LPFC bubble which can be seen here. Again, we have planned the surgery after 4 months. And yeah, so as I already told, ki there are two things you can do. Whether in oil in situ you can plan for the surgery, or you can remove the oil again. You can put the oil after the surgery. So here we have done the SOR first, and then we underwent all the procedures, and then SOI was done 5,000 CST. So drainage retinotomy were made in these particular areas, and ILM peeling was also done as there were extensive PVR. So because of that, ILM peeling was also done, and then membranes which are present in the periphery were also removed in this patient, and a silicone oil was put at the end of the surgery. So this is what the picture after the optos picture. You can see some drainage retinotomy over here. We just removed the oil which was behind the retina. So this is the comparative scan before there was PLC bubbles was present, and here it looks like a flat retina. So what we have learned from this particular case, trial of vitrectomy should be offered even in badly traumatized eye. Despite timely intervention, multiple surgeries, and good anatomic outcome, visual results may be poor, may not be good in that preference.
Can I ask a question?
Yes, ma'am.
Yeah, you showed a large bubble of subretinal silicone oil in your drawing. And then
Yes, ma'am.
but you said retinotomy was done to remove the subretinal LPFC. I'm a little confused. Was it subretinal silicone oil or subretinal LPFC?
It was subretinal LPFC, man. Clinically, it was a
Not
little,
oil, huh?
it was a little large
Okay,
bubble.
okay.
So it was thought that it was subretinal oil, but on table during the second surgery, we realized it was subretinal LPFC.
Why do you think it's not oil and LPFC? We had this OCD discussion. Why do you think that picture proves it's LPFC and not oil?
What is the position of the patient when this picture was taken?
Opto sitting, OCT sitting.
What happens to oil? What happens to LPFC?
So that is okay. Position wise, fine, absolutely okay. That's now restricted because of such RR scars and everything are there. It's not going to be freely mobile. But look at the OCT picture and tell why is it not oil and LPFC.
Sir, hyperreflective margins.
No, we're not looking at the hyperreflective margins. We're looking at something else. It was discussed, no, who made the LPFC class? Sorry, silicone oil, LPFC. Somebody had done. Shown us the difference between the LPFC bubble and the oil bubble. You had done it? Look at the angle at which you have the bubble edge. LPC bubbles will never be round in shape at all. It'll always be a dome-shaped acute angle at its edges. Okay, it is not hydrophobic or in any nature. So it just because of its specific gravity, it's going to flow flat on the retina, absolutely flat on whatever surface it is. It'll have an acute angle with the RP. It'll have a nice dome shaped. Even if it is a small bubble, it'll behave the same way as a large bubble. There won't be difference between the bubbles. But an oil bubble will be a bubble, circular thing. So it's clearly an LPFC bubble which is there, and the drainage, they drained it out. You can see the two bubbles also. Actually, see a large bubble there, right next to the fovea. There's no fovea also. Something's there next to that whitish tissue, the fold. You can see the bubble there. You can see the reflex from the bubble. It's subretinal, no? The retina over the bubble is stretched. You can see the two reflexes, one up and one down. Two bubbles actually.
So moving to our last case, a 26-year male, old male patient, alleged of history of RTA, diagnosed elsewhere as a right eye traumatic globe rupture with ocular content prolapse, for which corneal tear repair was done. So this was the slit-lamp findings of the patient. There was a vertical tear which was extending from the cornea to the limbus, and it was sutured elsewhere. The patient came to us with a vision of PL inconsistent. The globe was soft, presence of corneal sutures, edema, hyphema, and aphakia. This was a slit lamp picture of this patient. There was no fundus view. Left eye was absolutely normal within normal limits. USG suggestive of total retinal detachment. Again, we have done the same thing. We have just calculated the ocular trauma score, and it was 1 with raw points of 26 with this particular chart. We have done the ultrasound. It was a total retinal detachment with posterior globe funnel configuration with SNQ, INQ, and nasal serous choroidal detachment with axial length of difference of around 6 mm.
Which scan shows a close funnel attachment? The scan which is showing that 18 millimeter also.
Yeah.
Yeah. So
Yeah.
beautifully they put all the
Numbers.
numbers, everything, so that you cannot see only. So don't put such pictures. No, then what's the
Yeah.
point telling us that is a close funnel detachment?
Yes.
How will I know it's a close funnel detachment with all this 18 millimeters? I can say it's 18 millimeters. That's all.
Yes.
Right. Next. So either you put that another one which shows the close funnel.
Clear.
Here the audience doesn't know what is a close funnel here. The other one, the right bottom is showing reverberation echoes from the bubble which is trapped between the lids and the your probe.
Yes.
That is not giving us the idea.
Yes.
Second one is showing something. There's a tissue, some circular tissue in the center with all the diffuse low reflective dots. That is also not, there's no optic nerve to show us it's a closed funnel attachment to the membrane. It looks like a cross section of the. You put representative pictures of the ultrasound. This whole decision making is depending on your ultrasound, isn't it?
Yes.
Go back. Wait, what is that thing there? Superior to the line that you put. What is there up? What does it show? Why is there a defect in the globe? Is that because of hypotony?
The pressure was quite, maybe because of hypotony also, because the pressure was 4 at that time. Maybe hypotony indentation marks can be.
Chetan, why the reverberation is also there? Some air bubble was there during repair?
Sir, I don't know, sir. I mean, yeah, was there an air bubble there? See, this looks like more like, sir, they have not touched the probe properly, sir. They are too large. The reverberation is too large, sir.
Yeah.
And there is actually a gap between. So I don't know whether this is correctly taken.
I don't know. Again, intraoperatively probably will know, because very unusual to have a post-trauma, so much of hypema, all those things, and only serous detachment, choroidal detachment. There must be some hemorrhagic component has to be there anyway, or is a delayed ultrasound done. Sorry, earlier. Like, what is the duration between ultrasound and wound repair, primary injury?
So this is the when patient visited after only we have just done the
Yeah,
scan.
so how many
it was
days?
5 to 7 days around. Sir.
Let us see what your surgery shows. Let us see.
CT scan was not, there was no intraocular foreign body, but orbital wall fractures were present. It started with oral scleroids. We have just taken the opinion from cornea and oculoplasty also, and VP was also performed in this patient.
And just go back. Please do not write OD pre-thiacical globe, okay? This is still the trauma, the inflammation is there, everything is going on. It's an active disease, so to speak. You can't call it pre-thiacical globe. Inflammation is going on. It's hypotenuse, no doubt about it. So, but it doesn't mean that it's pre-thiacical.
Yes.
You can't label it as pre-thiacical here. Then if it is pre-thiacical, you should not tie anything also.
Yes.
It's still the active disease is going on. It's trauma related, acute injury related, all pathology is there. You should never write it down. Please don't write pre-thiacical globe.
Yes.
Even if you write pre-thiacical, please explain why you're calling it pre-thiacical globe at such a short interval from the trauma.
So VP was a history of no detectable waveforms. Again, we have done the ultrasound. As the relative were counseled that surgical procedure will not help, but still they are very keen of the procedure. So right eye we still tried vitrectomy or LPFC we just planned with PK backup.
Wait. So what is again that bump-like thing there on the top right? Sorry, left top image. It's a very unusual bump that is seen.
That is due to the hypotony, sir.
Because of-
again.
Yeah, and what is the ultrasound in the left bottom show? Yeah, what does it show?
Yes.
The left bottom picture. Left bottom picture shows something. At least you have the nerve there now. Yeah, so it seems to be there's a tissue which is going from the nerve to the lens echoes. Lens is there, right? It's aphakic. What is it?
Aphakic only. Aphakic. So axial length was 14 and OS was 24. It was quite a big difference of 10 mm. So we took the patient under GA. Sclerotomies were shifted according to the corneal scleral wound, but because closed funnel could not be opened up, so this case was called abandoned. What we learned from this particular case, shifting of cannula depending upon the corneoscleral wound. Iris hooks can be used if visualization is hindered by the iris tissue. Depending on the patient age and prognosis, we should decide whether we should go for the surgery or not. In this case, as the patient was young, though the prognosis was extremely poor, we still tried for the surgery.
Okay, one more thing, go back. See, don't keep, go to your points. Don't keep describing iris Sook's visualization.
Yes.
In a case of in trauma setting, you're not looking at iris Sook's and stuff like that.
Yes.
We're trying to clear the view for our posterior segment surgery, which we have to do absolutely nicely. I mean, if the iris is bound to some tissue, you have to cut it because you can't leave any tissue there which is going to act as a foci for PVR or anything.
Yes.
So the iris Sook's is not really important here for us.
Okay.
Shifting of cannula, I can understand. That you can keep according to wherever the trauma, the sclera is healthy and not
Yes.
boggy.
Yes.
So if you have a boggy sclera, you might want to avoid those areas where to put the cannula because it will not go inside also. Then again, and if there is enough cornea, healthy cornea, you put your AC maintainer. So please don't talk about iris Sook's.
Yes.
In the setting of, you can talk about iris Sook's when you're doing a different kind of surgery.
Yes.
When the posterior segment is okay, you're not talking about, or maybe RD is not extensive.
Yes.
Here you have a closed funnel RD. It's the RD which is stuck to the iris.
So in a nutshell, basic steps in traumatic retinal detachment. If the patient is having choroidals, we should train the choroids. If we can place scleral buccal or encircling buccal, if often desirable, due to if it permits, we can go for scleral buccal or encircling buccal. We can remove the lens depending upon the case. Just find the retina, peel retinal membranes, find the disc, identify and release the incarceration sites, flatten the retina, laser and tamponade.
In any of your cases, do you think bell buckle is necessary? So what you said is an encircling band is often desirable due to the high risk of PVR. Do you think PVR is already set in most of the cases that you've seen?
In this case too, he supported the dialysis with a.
Yeah, so that first case, yes, you can understand that. There's a shallow RD, and there was not much. How can you pick up indirect clues for PVR in ultrasound? So you're talking about proliferative vitreoretinopathy. So it's not always due to retinal pigment epithelium also. Here we have a break in the blood choroidal barrier, or any barrier has been removed. So we have actually got a fibrous proliferation into the eye now because it's open to the wounds are open to the elements. So we have fibrous proliferation rather than proliferation because of retinal pigment epithelium. It's not always that RP is exposed. So we have a fibrous proliferation, wound proliferation, basically wound-related proliferation.
Yes.
So what is the ultrasound? How the ultrasound will help you there? Telling you that indirectly there is PVR, and we can avoid a belt buckle altogether because it's be an unnecessary step in the case. Anybody can tell? So you have not spoken yet. So Garima.
The type of RD, if at all, it's looking like a closed funnel RD, that configuration of retina on ultrasound.
Yeah, so what configuration of retina?
Closed funnel RD, if it is, then we can expect PVR.
Okay, that is an extremely severe form of PVR.
Duration, if fresh RD or.
No, let's not go by the duration. I'm talking about ultrasound picture. No, on the basis of ultrasound, you can clearly say that let's not plan a belt buckle here. All the cases showed, all the cases. Just think about all the cases that were there. In all cases, there is some of the other form RR was done.
Any evidence of incarceration or posterior globe dehiscence
Correct.
is seen?
Incarceration. Incarceration is a site. So depending on how posterior it is, how extensive it is, you can decide whether you want to. So you've already decided that this is an incarceration. It has to be released from the posterior globe. That means you are anyway going to cut the retina. Supporting it with a belt buckle is not going to help. Anything else? This is incarceration. What about perforation? What about cases where your foreign body has gone through and through the eye, or an injury has happened through and through the eye?
Foreign body is located.
So many of times we have seen foreign body going right through and through macula.
No, I am here. I wanted to. Belt buckle generally, I think a decision generally we take intraoperatively. What you rightly mentioned, because these cases are so variable. Pathoanatomy was so different. You never can predict 100%. So you basically keep all the options open, and I think intraoperatively, lot of decisions are being taken during that time. So I mean, you cannot say before surgery, yes, 100% I am putting belt buckle, I am not.
So just like we discussed, Dr. VGP said he had opened the conjunctiva, he prepared the sclerotomies, because after you put the cannula inside, and then trying to open the conjunctiva, peritomy, tagging, it's a lot more difficult for you. You're doing things in a very hypotenuse globe, so it's better to do it before you open, before you put your sclerotomies, right? So that is what we are trying to say. But if the ultrasound gives you so many clues, you probably prefer prevent these steps altogether, because the decision making is important.
In a fresh corneal tear, if you have got a limbus to limbus fresh wound, in those cases, I will tell, and if you're just operating within 7 days, or just 1 week down or 10 days, the one may think of not putting a belt buckle for a very simple reason that the right from the word tagging till pulling the globe here and there is a high chance for the corneal wound to reopen. So many a times we have to keep that also in mind if it is an extensive primary wound repair and you are going in a bit early.
But if it opens during the tagging, then during the vitrectomy also it will open up, ma'am. So we have to augment that definitely.
There is no, I have personally seen this. That is why I'm telling that if it is a well-maintained wound in the corneal, whatever 3 sclerotomies that you do and go in every time and do, that pressure it does withstand. If it doesn't, you may have to put 1 or 2 sutures. But when you try tagging, all 4, pulling, again making scleral tunnels, and if they open, they just open. So one has to, and whatever you say, you have done the primary suture here, you have done the primary suture elsewhere, one has to keep this in mind.
Hello, nice discussion going on. I just wanted to add 2-3 more points. So first point is that some of the cases which Abhishek has shown where the patient has come with a full thickness open wound, and then he has mentioned that the other eye fundus was normal. So I would just like to inform that it is better to not waste time in dilating the other eye and seeing the fundus of the other eye when when there is an open globe. Okay, so I don't know whether that is the practice being followed, but it would be better not to do that because time is of essence, and that wound repair has to be done at the earliest. So you can see the fundus in the undilated state in the other eye at that time. And later on, once the wound repair has been done, the for the other eye fundus can always be pupil can be dilated and thorough examination can be done. But before wound repair, better not to waste time in doing this dilated fundus check of the other eye. Second thing is that he touched upon the timing of vitrectomy in these traumatized eyes, but he did not actually elaborate much on that. So basically the advantages and disadvantages of early versus delayed vitrectomy. So early vitrectomy, he mentioned that sometimes it can be done within 3 days. However, the problems in doing early vitrectomy are that the tissue planes are not very proper. There is edema. The cornea also is hazy. Your visualization will be poor, and oftentimes you don't have the outcome, favorable outcome. So whereas if you wait for the situation to become a little bit more controlled, the edema will subside, the visualization will improve, and even the tissue planes will get better defined. As you can see in you saw in the ultrasounds which he showed, where after wait initially when you do the ultrasound you will see all disorganized internal structure, which it will be very difficult for you to know which is retina, which is the what. And if you wait for some time, it will settle down, the choroidal detachment will settle, bleeding will settle, and you will be able to at least find your tissue planes while you're doing surgery. So it's important to wait for some time. So ideally you can wait for about 14 days. However, in situations where you have say endophthalmitis or a retained foreign body, those are the situations where immediate vitrectomy is necessary. All other situations you can wait. And this third thing is that this find the retina which he has mentioned is really very important, because often when you see inside, it is all all very disorganized structure. It is very difficult to know what you are cutting. So unless it is confirmed that what you are cutting is not a retina, do not cut it. Make sure that it is not retina. So that is very important. Thank you very much.
Thank you, ma'am.
Yeah, Chetan, couple of points would like to add. Uh,
Yes, sir. Please, sir.
Most important thing is PVR is generally different what you see in a trauma. You have more subretinal proliferation than preretinal. Of course, you get a preretinal, but subretinal proliferation is always more because probably subretinal heme, there's a significant amount of RP disturbance. So quite some time, I mean, you have more subretinal PVR, subretinal bands than preretinal bands. Okay. And PVR process again is a much prolonged. Like normal circumstances, what you say is the proliferation of cells lasts maybe around approximately 2 months to 3 months. PVR probably in a stroma eyes, probably process will continue to almost 6 months, sometime more than that. And that's why when you plan silicone oil removal, trauma eye generally will delay oil removal as compared to our regular RD and PVR cases. And third and most important is, I think, I don't know whether it's discussed, I missed that part. All these cases, extremely important is counseling, talking to patient and attendant and making them understand they have to be realistic as far as prognosis is concerned.
Thank you, sir. Yeah, Abhishek can conclude.
To conclude, some take-home messages for the management of traumatic RD. Trauma is full of surprises, so be prepared for intraocular challenges. Careful preoperative history examination investigation like USG and CT to be done. Course of oral steroids can be started early on. Close serial follow-ups to decide operability. No PL patient with traumatic RD may also be offered a trial of surgery. Sometimes, despite multiple surgical interventions, end result may be poor. Controversy is still present when to operate, but ideally should be operated within 10 to 14 days of primary wound repair. Depends on multiple factors like systemic stability, media clarity, wound strength, presence of RD, clot lysis of hemorrhagic CD, availability of corneal tissue if you are planning for a combined surgery with PK. May need to plan surgery under GA when expecting posterior wound or recent primary repair. Aim of surgery and prognosis should be clearly explained to the patient and attenders.
Yeah, just Abhishek, one more thing here. Not
Yeah.
many to plan surgery under GA. Most of the time, ask for GA clearance because your first sentence, what you say, trauma is full of surprises, so you do not know what you are going to deal with.
Yes,
So always trauma cases, ask for a GA clearance.
Yes.
You can take a call on the table whether you want to convert to local or not, and when we are very sure about what exactly you are doing, but it's better always ask for GA clearance.
Yes.
And last point, you said abandoning a case, right?
Yes, sir.
So in all cases where you attach retina, you can give them some hope at the time of closing the wound and saying everything is all right, we could manage everything. But if it is abandoned, please don't say that time.
Yes.
If it is under GA, you anyway don't have to worry too much about it.
Yes.
You can always go back and counsel the attendants and the patient much later.
Yes.
That you can probably just delay the counseling a little bit, so that if you tell them on table, they are going to be very upset. You can tell them a little later. Just say that we are not able to identify retinal structures, a lot of hemorrhage. So we'll think about the next step later on. Don't tell them abandoning and all that stuff right there and then.
Yes.
Also, Chetan, I think make it stress it that this counseling should be done by the consultant. It is better that the fellows do not, speak about the abandoning of surgery, because it is very important how you put it across to the patient and the attender. So it is sometimes the relatives may ask the fellow how the surgery went and all. So at this situation, during such a situation, the fellow should not, speak or let the consultant handle this, because this needs to be handled very carefully.
Thank you everyone for attending the presentation. May I extend my regards to PV sir, the GP sir and JSN.
Yeah, nicely done, Abhishek. Quite exhaustive, actually.
Thank
Well
you,
done.
Thank you.